explain to us into details what DVT, is, the symptoms. You also touched on the treatment, and I think that's where we ended the conversation. So we'll go on, we'll continue from there. But just as a quick refresher, for those, also for the benefit of those who couldn't tune in last week, when we say DVT or deep vein thrombosis.
Yeah, you got it. Thrombosis.
The way you laugh, say this is spotted. You let me say DVT. What kind of condition is it for the uninitiated?
So DVT or deep vein thrombosis is so thrombosis and deep vein. So thrombosis is when a clot forms within a vessel. Okay, and usually the vessel should be deep seated. And commonly where it happens is the lower limbs. Okay, it can also happen somewhere in any other part of the body, the pelvis, but commonly you have it in the lower limbs. So you have you need certain conditions for a thrombus or a clot to form within the vessel. So the vessels can be likened to pipes. So you have a pipe, regularly at home you have your pipes, and these pipes would receive water and then would transfer the water all the way. Then you get, when you open your taps, you get water coming through it. Okay, so in the same vein, when you are talking about veins, arteries, vessels within the body, they are your tubes, or yes, so basically your tubes that would be able to also connect to your heart. So either they are carrying blood from the rest of the body to the heart, where it is oxygenated, it goes through the lungs, it's oxygenated, and it goes back into the body to the cellular level where the oxygen is utilized, and then so on and so forth. So it's like that pump system within the body. So now when you have a clot forming, so a blood clot forming within the deep veins within the body, and usually the lower limbs, then you have deep vein thrombosis happening. And you need something we call the Verkhoff triad, 3 main conditions for a clot to form within the veins. So your endothelium is the lining within, the innermost lining of these tubes that I'm talking about, or your veins. So if you have some endothelial damage, or the cells within the endothelium, they are damaged, that would predispose you to form clots within the vessels. And then also when you have hypercoagulable state, so coagulation is basically, these are factors that are found within, protein factors that are found within the blood itself, so your plasma. So usually they are insoluble. Okay, usually, they are rather soluble. Okay. So then when they become, when you stimulate them, they become insoluble. So insoluble, that means that they can now become solid, so that they can stop whatever that is causing the injury. Okay, so when you have hypercoagulable state, that means that you have a lot of these clotting factors in there that have been activated. And have stasis. Stasis is slow movement of the blood within these tubes. So once it stays there, that means that it's sluggish. So if it's sluggish, it means that now you would have that time factor to help for the clot to form. So all of these 3 factors are very necessary for the formation of these clots that we are talking about.
I recall you saying last week that it could be a life-threatening condition to have.
Once it becomes complicated, especially so when these clots do form, they do form in the lower limbs, as we have mentioned, and then you are not very fortunate, and then these clots then break. So when they break away from where they have formed and they start to travel, we call it embolism. So you have clots forming, and then now it is traveling to other parts of the body, especially when it travels and then it goes to the pulmonary vessels, that is the vessels within the lungs, and then it can lead to what we call pulmonary embolism, and then that is life-threatening, and that can lead to death. Yes, so that is, yes, what you mentioned.
We'll continue with the treatments, right? And I also recall very briefly you talking about how lifestyle changes, can play a very key role in dealing with the treatment. But are there, we'll come to lifestyle changes, all of those things.
Okay.
But are there like specific procedure you can, undergo to deal with this?
Yes, so usually DVT, once you have DVT and been diagnosed, diagnosis is basically, from your signs and symptoms, and then you go on to look at certain investigations that you have to do. So investigations, you have the regular hematological investigations where you can do D-dimer test, and then for DVT patients, most of the time you have very high levels of your D-dimers. So your D-dimers are just byproduct of any clotting that has occurred within the body. So you have those fragments within the body, and then it can be picked up as that's investigation. So once that is confirmed, and then also the fact that you can also do an ultrasound, Doppler ultrasound of these vessels. So once you do these ultrasound and then you notice that there is a clot there, yes, that is also diagnostic of the fact that, and also there are other things, aside the signs and symptoms that I have mentioned, there's something we call the Wells score that looks at some of these risk factors and then also some of these investigations, and then it's scored. Based on that, it gives you a high index of suspicion that this person has a DVT or this person does not have it.
Can the clot travel?
Treatment, yeah. And then the treatment is basically, it's medical treatment, and then the surgical aspect of it in cases where the medical treatment is contraindicated. Eno was just mentioning that can the clot travel? Yes, it can. So once it breaks, as he mentioned, so once it breaks and then it starts to travel, it now becomes an embolus. So an embolus, wherever that it goes to, which part of the body that it goes to, and then it causes some blockade, then you have some manifestation of that system. The patient would present with those manifestations, and one of them which we don't want to happen is what I said, when it gets to the pulmonary vessels, and then it causes that you can end up with a life-threatening situation,
but
and that can actually
for those who don't show any obvious symptoms, I think you touched on that very briefly too. Like how do you? There's a word you guys use, trying to, assess whether one is in a particular condition. So how do you? What would even prompt you to say, oh, maybe this is a DVT, when it's very obvious that there are no symptoms?
Okay, so you'd have to look at sometimes the history around the person.
As in
so one of the
history?
Family history may play a role. I would explain that. So family history comes in when you're talking about the coagulation factors. So if you do have certain inheritable factors that predisposes you to forming clots, like you don't have protein S, protein C, and then sometimes even antithrombin 3. All of these are some inheritable factor, risk that if you do have it, then it means that you are prone to having coagulation, or you are prone to your blood moving from the soluble to insoluble. Okay, yes, so that is one of them that can play a factor in you being predisposed to getting DVT. But the other thing that you, what again? What
I was asking you around the symptoms.
Yes,
right?
so the symptoms, yes, basically. So the symptoms basically would be that you may have some unilateral leg swelling.
Yeah, you mentioned
that. Yes, that may have some temperature. Okay, so increased temperature, and then pain at the calf.
How is it like, is
so
it like
intense pain?
Is it
intense
or
pain
sharp
around,
or piercing
yes.
or?
So it's usually very sharp pain around the calf. So that's just behind you.
In medical diagnosis, is that a symptom? I feel like symptoms are what you can see, right? Or also feel.
Symptoms are what the patient will tell you, and signs are what the doctor will pick up.
Is it?
You get
how
it.
then do you tell the difference between a muscle pull? Because muscle pulls
Yeah, so
normally
exactly
happen
the
around
question
that
was coming to.
area
How do you know
as
the
well.
kind of pain is not from like some leg injury
Okay.
Or a muscle pull.
Exactly.
Like, how do you
Yeah.
tell the difference?
Yeah, so you see, usually muscle pull just doesn't happen.
Yeah.
It may be preceded by some strenuous activity that you may have done.
Yeah.
So that would point more towards that. So you would have to look at the history around it and then marry it with some of the symptoms that the patient will be telling you. And then you would also juxtapose it on the signs that you pick up. So muscle pull, and then most of the time for muscle pull too, is because of you may have had an injury there or there's some inflammation going on there. So usually it responds to some of these analgesics that you give, some of these painkillers that you give. So when you give the patient these, they tell you that, oh, it's coming down or it's resolving, as opposed to that of DVT. That of DVT would not respond to some of these analgesics that it's giving. So I agree with you, it's a very thin line.
Yeah.
But then when you look at all of these,
I mean, doctors are
history-
magicians, right? You know, this week I think a particular school, you know, had a pass out for doctors, they were,
Okay.
you know, fresh doctors,
Yeah.
and there was a conversation on social media around, you know, the profession, young doctors, and I remember a post from a young guy who, you know, also graduated, you know, and he had like a picture of the human anatomy with all the many different veins
From
within the
muscles,
body,
veins
yeah,
to-
you know, and they were color coded.
Yeah.
And one person said that, you know, his shock in medical school was that his shock in real life, you know, medical school practice,
Yeah.
training and all of that, is that when, you know, they see the things on the signpost color coded, but in real life there's no color code, you know, and there are so many of the veins, you know, so how do you know
Exactly.
this is the, you know, it's
Yeah.
but I guess it's the beauty of it. Amazing.
Exactly.
So that's how you're able to tell for the symptoms.
Yeah, so that's
How
where
about
you're
the
able
red
to
patches
tell.
that form?
So usually not so if it's erythema. So erythema is you would see that particular limb has changed color. It looks, especially you would see it more in people who are fair colored. You would see that, okay, when I compare the unaffected limb to the affected limb, there is some color change between the two. Not only that erythema, generally, you would also feel that there is temperature change. So the affected limb may have an increased temperature. Okay, it will be a little hypothermic compared to the limb that is not affected. And then there will be changes in the size of it as well. So when you use a tape to measure the circumference around the affected and unaffected, there is some discrepancy showing that there is some swelling with the affected limb. So these are some of the signs that you
What
pick up.
treatment options are available for people that, you know, after their diagnosis and all of that?
All right, so treatment options, medical. So medical, you go on, you be put on something we call the blood thinners.
Is that safe?
Oh yes, it is safe. It is safe, I'll explain, in the sense that you are just not put on it and then left, you'll be monitored.
Okay.
Okay, so blood thinners would reduce the rate at which you form clots. But also, it means that you're at risk of bleeding if you should have an injury. Okay, so that is why I say that you are just not put on it, but you are monitored as you are put on it. And it's also within therapeutic levels that you are put on. So usually you'll be put on some anticoagulants. So these anticoagulants, depending on the setting of care, so if you are an inpatient, you'll be given some of these subcutaneous anticoagulants. Others too, you can be given and you will be switched to some of these oral anticoagulants as well. Okay, so that is what, and usually when you are put on warfarin, for instance, you need to be monitored and you need to be doing some of these investigations like your INR or your clotting profile. So you are put on it, you are put on, and then you take these blood investigations to be sure that your INR is within the therapeutic levels, and then you would also be told as to what some of the activities you're supposed to be doing and some of the activities you're supposed to refrain from, so that you don't end up getting injured and then you end up bleeding excessively. So for certain patients where you having to do medical treatment for a while and you notice that they are still not improving, then it means that you may have to do certain or you may have to intervene surgically. So yes, there are certain surgical interventions that you would have to do with vascular surgeons, where you would go in, locate where the clot is, and then you retrieve the clot. Okay, so it depends. And then certain people too may have some conditions that will contraindicate for giving them the medical treatment, and then all of those are candidates for the surgical management as well. The most important thing is that you do not want further clots to form. That's one. So these medical treatments will not break down the clot that has formed, but rather would prevent further clotting from happening. And then, aside that, you would have to give the patient certain advice or counseling to make sure that they are doing some exercising. Okay, so most of the time, as I mentioned from the beginning, I said that you have stasis. Stasis is that the blood becomes sluggish. So what can you do to prevent the blood from becoming sluggish? So you need to do active, passive exercises. Okay, so anytime you think you're indulging in any long activity where it will require you to be stationary for a very long time, at least take breaks. So after every hour, you can take a break and then walk around. Those who are in long flights, even with that, after an hour, you can walk through the aisles and all of that. And then even if you can't walk within that period, you just need to do your active passive movements, where you would point your toes upwards and then downwards. In that sense, it helps with the activation of your soleus pump. Okay, so the muscle that is just behind or around the calf, it helps to contract and relax that muscle. And that is what helps with any blood that has pulled down there would then be pushed back and back into circulation, and that reduces the stasis that I mentioned. That is one of the main factors that you need for DVT to form. And also, aging is one of them. Aging, once people are aging, you notice that they become very, they are not as active as they used to be before. So you still need to make sure that once you are aging, you still have to engage in certain activities, even if it is not very rigorous exercises, but you should still do some exercise to prevent.
The word is just escaped me. The prevalence.
Okay, so about, I mean, globally, about 300,000 people are diagnosed.
Globally?
Globally, yes, 300,000.
If I get it, am I at risk of getting it again?
Yes.
So it's like a long lifetime?
No, so if you get it, you are at risk of getting it again.
Okay.
But what you have to do is that, as I mentioned, there are 3 factors. You need to be able to modify those 3 factors so that you don't end up getting it again.
In a world of 7 billion people, 300,000 feels like a drop in the ocean.
In the ocean, but it's still because of the high
globally
mortality. Exactly, because of the high mortality.
It's a major
exactly.
issue.
Once you
if it's
get
300,000 globally, then in Ghana, probably further.
In Ghana, I don't have the statistics.
The data.
Yes, but then most people who report tend to be either they report to the hospital and they are picked up, or those who may have undergone certain major surgeries. So maybe a pelvic surgery, or a lot of, you can even just oppose it on the number of people who get accidents and then they end up with fractured limbs, okay, and then they have to undergo fixation of these limbs. So if they are immobile for a long time, so it's one of the protocols that is used. Once the limbs are fixed and they have to be immobile, they have to be prophylactically anticoagulated against DVT. You get it? And people who have malignancies, so they have certain cancers in other parts of their bodies, that also predisposes them to getting a hypercoagulable state, and then eventually, so you can look at all of these risk groups, and then it can give you a fair idea of what we are dealing with if any of these risk groups end up getting DVTs.
Is it hereditary?
Yeah.
So as I mentioned,
there's family history, right?
Yes, so family history basically on the protein C, protein S, and then antithrombin 3. So all of these, they help to prevent you having a clot forming. But then if you do not have it, you have deficiencies of these, it means that you're at risk of developing clots much more often. And these are hereditary. So eventually, yes, you can end up having some hereditary components when it comes to DVT.
Pregnancy?
Pregnancy as well is also another risk factor. Pregnancy, because of the hormonal surges, you tend to also have hypercoagulable state in that sense. Aside the hormonal surges, also because of the gravid uterus or the pregnancy, tends to cause it compresses on the big vessels. So if it compresses on the big vessels, it means that you have pooling of the blood. And if you have pooling of the blood and you are unable to get the blood back into circulation, and then you have stasis, yes, you're at risk of developing DVT as well when it comes to that.
Wow. Doc, I feel like I can give a whole lecture on DVT, right?
Yeah, you should be able to.
From a position of complete ignorance to.
Yeah, and then, you know, a lot of people are not aware of it and they do not take precautions, especially when they are traveling.
Yeah.
Okay.
Yeah,
so there are certain times, most of the
still,
times you hear that, oh, this person was so healthy,
yeah,
and then went on a flight.
And
as soon as they landed and the person got off the flight,
and they died.
the person went unconscious, and that was the end of it. Yes, it's likely it's a DVT. And once they started walking, there was an embolus and it went into the lungs.
Wow.
They ended up with a P.
Do compression socks, I mean, on long flights help in any way?
Yes,
or even if you're not going
help.
on a long flight,
yes,
can you
does.
wear it?
Exactly, it does help. So it does the similar work as the soleus pump or your muscle. So it augments the action of the muscle, and it helps with pumping the blood that pulls down there within the limbs back into circulation. So yes, it does go a long way to help. It's one of the prophylactic ways of preventing DVT. Yes, so it does go a long way to help.
Doc, thank you so much.
Thank you so much.
Thank you too.
Yeah, a real blessing, you know, for the insights you bring to us. Of course, not only us, all our lovely viewers out there. You know, there's free consultation, right?
Yeah.
Can you imagine?
When I come to the hospital, they pay.
I went to some hospital. Yeah, the airport, please.